Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access at stepsforward.org.
Hello, and welcome to this episode in the AMA Steps Forward podcast series. I'm your host, Dr. Kevin Hopkins, a family medicine physician at Cleveland Clinic and physician director of health system engagement here at the AMA. I love vacation. There's not much I like more than getting away from the office or from home with my wife and kids. Historically, our family of five has preferred Caribbean beach vacations, soaking up the sun with plenty of time relaxing with good books. As our kids have grown up, we've been taking more vacations to national parks, seeking out active adventures amid jaw-dropping views. While traveling home, we nearly always start talking about the next getaway. How many vacation days do you take in a year? And I mean, really take off, like totally disconnecting, not doing any work-related tasks, not reading emails, not thinking about how to solve a problem at the office, or even reading about the symptoms of that one patient you just haven't been able to diagnose. Time away from work responsibilities to rest and recover from work-related physical, mental, cognitive, and emotional demands is crucial. Physicians typically have 25 to 35 days of paid time off, or PTO, each year, and yet many of us don't take nearly that much time away. Our guest today is my great friend, colleague, and mentor, Dr. Christine Sinsky. Most of you likely know her name and are familiar with her work as the leading champion of physician well-being. Having retired at the end of May 2025, Dr. Sinsky is an internist and the former vice president of professional satisfaction here at the AMA. Chris, it's such an honor to have you as a guest on the podcast today.
Thanks, Kevin. I'm delighted to be here with you.
Well, thank you. And before we get really started into our conversation, would you mind telling our listeners a little bit more about yourself and your background?
Sure, Kevin. So I'm a general internist. I worked in Dubuque, Iowa in a multi-specialty practice for 32 years. 16 of those were before the EHR, 16 after. Didn't have a lot of inbox and work on vacation during those years. And for the last 12 years, I've been leading our work on improving professional satisfaction and reducing burnout for physicians and their teams here at the AMA.
All right, thank you. So, and we're going to be discussing an article you authored along with Purva Shah and Lindsay Carlasari from our AMA team and with Dr. Tate Shanafelt from Stanford, which was published in Mayo Clinic Proceedings in May 2025. But before we even get into the specifics, could you articulate for us your view on the importance of physicians taking time off?
Sure, Kevin. It's kind of like what you said at the beginning. We all need that time to rest and recharge and get away. And in small ways, we need that in our evenings and our weekends. That's part of it. And then vacation is also part of it, those bigger cycles of rest and recharge. In a sense, patients are now always with our physicians. That sense of responsibility is always with you. And I think that's a really key evolution for us to recognize and articulate. And without intentional systems of full coverage in place of those patient responsibilities, I think it's harder for physicians in today's world to fully and safely unplug from work, and then to experience those moments in small and larger cycles, those moments of rest and recharge, whether it's evening or weekend or longer vacation. And yet I think we need to get that refreshment to really effectively carry on.
If you don't mind me asking, when was the last vacation you took and how was that?
So I have called myself somewhat vacation impaired, but I have taken two fabulous vacations in the last couple of months, one of which I got back from 2 weeks ago, and it was a biking trip to Italy. And it truly was a time to unplug. Prior to that, I took a biking trip to Patagonia in Argentina.
Well, both of those trips I've heard some about, and I know they were amazing and that you had a wonderful time, and hopefully we're able to rest and relax. So, thinking about how much time physicians take off work, or more accurately, maybe don't take off work, I've been a health system leader for years, and on the surface, thinking about it as like an administrative leader, having physicians who don't take all of their allotted time off, it sort of sounds like a good thing for the system. So if physicians are seeing patients and doing procedures on a day they might otherwise have been out on vacation, this allows more of our patients to have access to their care and expertise, and the practice or the system to have more productive days from them. But I think I know how you're going to answer this question. Is that perspective a little short sighted?
Yes, so I think short sighted is really the key adjective here. In the short term, what you say may seem to make dollars and cents sense, but in the long term, it's really expensive for healthcare organizations when their physicians don't take full vacation. By not taking vacation, there are other adverse workforce outcomes that come to health systems. Higher rates of burnout for physicians who take less vacation or who do more work on vacation. And it may even shorten a physician's tenure at their organization. It may contribute to the decision to depart the organization, and that's very expensive for the healthcare organization that loses a physician. So that little bit of dollars and cents gained by the physician working rather than taking vacation is lost many full times over when that physician leaves early. It costs between $800,000 to $1.4 million to replace a physician who leaves an organization. And if you're losing physicians because of burnout, because of doing work on vacation, because of not taking vacation, you can quickly see the cost of that.
So I'm interested particularly to hear more about the association with burnout and longevity in an organization. This study I mentioned that was published in Mayo Clinic Proceedings that you helped author. It's called Association Between Vacation Characteristics and Career Intentions of U.S. Physicians, a Cross-Sectional Analysis. And I know that it found that nearly half of physicians reported taking fewer than 15 days of vacation in the last year, and something around 10% reported taking 5 or fewer days. You mentioned a little bit about it. What are the bigger risks associated with this type of pattern?
Sure. So in this study, we analyzed the survey responses of over 5,000 physicians in the US. And we found that those who took less than 3 weeks of vacation had 34% higher odds of intending to reduce their clinical effort to part time. That's a coping strategy that physicians take. Nearly 20% higher odds of intending to leave the organization. And again, both reducing your clinical effort or leaving the organization are quite costly for organizations. We also looked at two other vacation characteristics. So physicians who don't have full inbox coverage when they're gone, and thus out of a sense of responsibility to their patients, feel the need to continue to monitor and respond to the inbox while on vacation. Those physicians also have higher odds of intent to reduce and intent to leave. And then finally, those who do work on vacation are at very high odds of burnout and intent to leave and intent to reduce.
So, what are the most common barriers that you've learned to physicians feeling like they're able to really unplug and take vacation time and really disconnect?
We found that there were three main barriers that physicians raised. One was the challenge of finding someone to cover their clinical responsibilities. Physicians don't want to impose on their colleague. They know what a burden the inbox is. And then if they're asking their colleague to spend several hours a day responding to their inbox messages on patients they don't know, that's a difficult social situation to be asking that much of a colleague if it's not systematically built in. Another key barrier was the fact that there will be a large volume of inbox work that the physician will face when they return from vacation. So I think a lot of physicians may feel like, well, if I spend 30 to 60 minutes every day just kind of keeping up, then I won't end up with this massive, daunting work of working my way down the inbox when I return. And then thirdly, for some, there's the financial impact on compensation, that fewer days worked means lower compensation, lower productivity, and particularly when they're compared to other physicians who might be also not taking full vacation, then that sort of sets the bar higher for how much productivity you need to make to earn a certain bonus, for example. So those are the three main reasons.
So I'm fortunate. I work in a practice where I've never had to find somebody to cover my inbox while I was away. I sign up to a covering physician pool, and messages get handled while I'm away. And I come back, and it's almost like starting afresh. There's no expectation that covering physicians handle what's stuck in my inbox that maybe I haven't addressed. And that's about the only time my inbox is empty is when I go out on vacation. Is that not typical that there's a system process or structure in place for inbox coverage?
So I think there are several models, and the model you just described is one model. I don't think it's universal. I think that it's not uncommon for physicians to have to informally find that coverage as opposed to having it formally built in and equally distributed. Another model for that coverage is one that relies more heavily on skilled team members. For example, having a skilled and stable nurse physician partnership. That was the model in my own practice. So in our practice, there was a tight relationship between the primary nurse and a physician, and those two people worked together every day, month after month, and in most cases, year after year, and even decade after decade. And the nurse in that situation then is the primary owner of the inbox and is the first responder to the inbox. So when I was on vacation, oftentimes my nurse was not taking vacation and she would still manage the inbox. If she happened to be on vacation, then the nurse on call would handle that inbox. And any urgent messages that needed to be addressed, that nurse would take them and verbally discuss them with the physician on call for our practice. So it took much less time per message for the physician to resolve that message. And then when my nurse was gone on vacation, we had a half day for her to catch up with any inbox messages that were not urgent and therefore managed by the on call nurse and on call physician, but that she would then manage.
Okay. And I also heard you say one of the barriers can be just the potential large and overwhelming volume of messages that a physician could return from vacation to in their inbox. And I think you said it's a coping mechanism to do a little bit of that work every day while you're on vacation, just to try to tread water and keep up. And that's probably something that many of our listeners have done. I know I've done it before in the past. Is Have you learned anything about that? Is that a valuable coping mechanism, or is there inherent danger in that?
Sure. Well, first of all, I'll say it's common. In our study, we found that nearly three-quarters of physicians report doing some kind of patient work on a typical vacation day. Just think about that. Nearly all physicians are doing some kind of work nearly every day while on vacation, some kind of patient related work. And fully a third reported doing 30 minutes or more patient care work on a typical vacation day. So there really is this really massive intrusion of work into one's time away, the time to experience real time off. I know one of our colleagues has renamed PTO pretend time off instead of being paid time off because you're not really unplugged in many circumstances. So, said another way, I think it shows that a lot of the time, vacation really isn't full vacation. You had asked me about my own experience with vacation, and it made me think of another time where I was on a hiking trip for 3 nights in the desolation wilderness in California, and there was no cell reception. And I had an experience of euphoria because not only was I disconnected from work, which really wasn't a big part of my own professional experience, but I was disconnected. And we so seldom experience that experience of encountering life as it is without the electronic interface. And so I extrapolate from that also how valuable time away from work responsibilities are.
Yes, I have very few experiences of doing that purposefully. Most of the time, it's because I've forgotten my phone or because the battery has died. But you're right; it is sort of a sense of freedom and not necessarily being tethered to a device. And even years ago, I got tired of carrying two phones, a work phone and a personal phone. So I distilled it down to one. But even when I look at my phone for for personal things like a text with a friend or a message from one of my kids, I'll get distracted because I notice something from work, and then all of a sudden I've gone down that rabbit hole, and I'm not really disconnected. I'm still tethered, even if it's by a finer thread.
And then that tether holds with you throughout the rest of the day. It's not just those few minutes that you were thinking about work or that 30 minutes of doing inbox work. It's as if your mind is still at some level working through those work related responsibilities. And I really think it's important not to attribute responsibility for vacation characteristics and vacation behaviors solely on the physicians themselves, because I really believe that it's related to institutional support for individual self care, so that physicians who don't have a systematic approach to cross coverage, whether it's by a fellow physician colleague or a nurse partner, physicians who have a compensation model that may penalize them for taking vacation, those are things that institutions have the ability to modify. And so institutions can make it easier for physicians to take care of themselves by how some of these things are structured. One of the things that's come out of our study is we've been able now to estimate the cost for an organization of not supporting these healthy vacation characteristics. So we know, for example, using published data in the literature, that an organization of 500 physicians that might have average characteristics for vacation behavior, taking less than 3 weeks of vacation, no index coverage, work on vacation. So if they had numbers for those three characteristics that matched the national norms, that organization would be spending $2.4 million a year to replace three physicians who left because of the fewer days of vacation. They'd lose five physicians because of not having full inbox coverage at $4 million a year. And they'd lose five physicians for doing work on vacation. So that organization is losing $10 million a year related to suboptimal support for healthy vacation characteristics. It's just not captured in the bottom line. So we have put those interactive calculators on the AMA's website. And so an organization can put in the number of physicians that are in the organization. If HR data or other data is available about number of days of vacation, that can be put in. If data from the EHR is known about work being done on vacation days, that data can be put in. And the organization can begin to have insight into what it's costing them in these interstitial spaces, what it's costing in ways that aren't showing up on the bottom line, but are related to the cost of replacing physicians who leave because of these characteristics.
Right. There's a cost associated with everything, and even for physicians not taking vacation, there's a cost associated with that. And you're right. It's just not realized in how we do our budgeting and those types of things, but it's there for sure. So, what are some things that healthcare organizations can choose to do to better support physicians to fully disconnect and recharge, taking while they're taking their time away?
Right. Great question. Because really clearly, organizations that develop the infrastructures and the cultural norms to encourage both the taking of one's full allotment of vacation and equally as important, to fully unplug from work while gone without the worry of the avalanche of inbox messages or worry about overloading a colleague or worrying about leaving a patient in the lurch. Those organizations will have lower rates of burnout within their organization and higher retention. So what can they do? So thankfully, three physicians, Jill Jin, Marie Brown on the AMA staff, and Diane Shannon, have written a Steps Forward toolkit on real PTO, how to reduce barriers to taking time off. And they've got some really practical suggestions along with some fundamental principles. So one of the suggestions is to transition all patient care and EHR responsibilities to team members without guilt about burdening colleagues. And I think that's a key part of that underlying principle. The second principle is provide adequate lead-in and catch-up time before and after time away. So, for example, that half-day slot that my nurse had to catch up when she returned from vacation, or when we both returned from vacation. And then the third principle was to adequately account for taking the full allotted PTO and compensation models. And so it's lots of little things, first understanding the business case for real PTO, normalizing the culture of taking time off. Leaders can lead by example, and instead of sort of pounding their chest and saying, I almost never take vacation, could actually be really transparent about when they take vacation and why they did and how good it was for them. Normalize that culture. Organizations can track the time off that their physicians are taking, and then actually reaching out to those who aren't taking vacation and encouraging taking of more vacation.
I love what you said about normalizing the behavior, and making it part of the culture. Because I think for a long time, our healthcare culture, particularly among physicians, has been that we play the role of the martyr, and I'm going to keep working even if I'm sick. I'm not going to take vacation time. I'm going to miss my kids' events, and that's okay because I'm a doctor. And I think the culture is changing where we realize, well, no, that's really not okay. It's not okay. And honestly, no one will remember that I was the martyr in this particular situation and didn't take all my vacation time. Nobody's going to remember that.
Yeah. And Kevin, I think it's related to pajama time. And I think it's equally as important for organizations to normalize not doing work outside of work. But just like the organizational leaders can normalize that, we all need to build the infrastructures that make that possible. Make it possible to complete work at work rather than expecting physicians have the second unpaid job after work on the evenings and on the weekends. And so I think linking both vacation experiences with evening and weekend experiences, I think is important.
So for an organization or practice that invests in really supporting physicians to take their time off and to unplug and disconnect, what's the ROI? What's the return on investment with that? And what should we expect to see as far as a benefit related to physician professional satisfaction and retention potentially?
Right. So we can expect that if organizations do actually create a culture and create the workflows and the infrastructures that support vacation, that they will save millions of dollars every year because they won't be losing physicians. And so, although I can't give you, the ROI is, 2 to 1 or something like that, we do know that when people take their vacation, when they have inbox coverage, when they don't work on vacation, they don't burn out. That saves a lot of cost to the organization. It saves reputation. It improves the patient experience. It improves the quality and safety of the care that their organization is able to deliver. And so all of these are financially beneficial to that organization.
I know you said taking 15 days or fewer of vacation per year, not having full inbox coverage while you're away, and spending more than 30 minutes per day of work on vacation, that each of those are associated with higher odds of intent to reduce clinical hours and intent to leave your current practice. Is that correct?
That is correct. And it's also important to note that they're independently associated with those outcomes. So even after you've controlled for taking less than 3 weeks of vacation, not having inbox coverage, doing work on vacation independently is associated with higher rates of burnout, which has its own costs and negative consequences, as well as higher rates of intending to reduce and intending to leave. So the impact of each one of those characteristics is independently associated with those costly outcomes for organizations.
I want to go back to something you said earlier, and asked a very specific question about compensation model, because you said barriers can be, if I'm not in the office seeing patients all next week because I'm on vacation, depending on my compensation model, I don't get paid, or I don't get paid as much, or I might not hit my bonus targets, things like that. How can practices and organizations help to support physicians to take time off in a compensation model that depends on that type of productivity?
Right, right. There are pros and cons to purely salaried models compared to purely productivity based compensation versus hybrids. In a purely productivity based compensation model, I think here the onus is on the individual physician to recognize what makes for a better life and to work every day of every year just to bring in more RVUs, to bring in more dollars, to have a higher salary. It's somewhat what you said. The end of your life, is that what's going to make you happy? Or is it going to have been having meaningful experiences with your family or your friends? It's really in the hybrid model where I think institutions have the opportunity to intervene. And in the hybrid model, you've got salary, but then you've got a percent of your productivity, a percent of your compensation that's connected to productivity. And many organizations will say you get a higher percent of that if you're higher up on the benchmarks of our organization or of national comparative benchmarks. And if we're comparing to physicians who work 52 weeks a year, and 52 weeks of your own productivity is what goes into that benchmark, then you can see how we can end up with a vicious cycle. So organizations could choose to say, we're only counting 46 weeks when we do these calculations for either a productivity bonus or whether you meet that higher target to get a higher percentage of your productivity. There are many ways that an organization can remove that incentive for 52 weeks of work a year. And the rationale could be, as an organizational leader, I could say, I know it's in my organization's best interest if people take vacation. So if we're incenting people to take less vacation by the way our compensation formula is structured, we have an opportunity to modify that.
Great examples. Thank you. What tools or resources would you recommend to physicians and health system leaders who are really looking for effective ways to optimize the value of time off?
Yeah, I think there are three key resources and three key approaches that I would suggest. Two of them might seem a little bit remote, but I think they're actually closely related, and they get to the practice fundamentals. So one is to reduce the volume of inbox work in the first place. So going upstream of upstream and saying, we've got inboxes that are full of all kinds of notifications that don't even need to ever come to the physician's eye, that some of them can be removed out of the gate. We don't need 6 admission discharge transfer notifications for every hospitalization to reach the physician's inbox. We can take systems approaches to eliminate those. Other things can be addressed by an upskilled team and still never reach the physician's eyes. So lots of results that come into the inbox, those can be managed by, for example, the RN on the team, if that RN has a tight relationship with 2 or 3 physicians and is managing that inbox for them. And then we can make it easier for physicians to respond to those few inbox messages that require the physician. And all of that then decreases the inbox burden, which reduces that impulse to keep up with it while you're gone. It reduces the burden that coverage by another physician or another clinician of some sort is, because there isn't as much volume in there to go through. So that's one resource, is addressing the inbox head on. And we have a Steps Forward toolkit on taming the inbox. A second is developing advanced models of team-based care. And with advanced models of team-based care, we have higher staffing ratios. So more medical assistants and or nurses working with a physician and staying in that stable relationship over time. And as that skill level is higher, as that stability is higher, as the size is greater, then more of that inbox work can be shared with team members. And here I'll just segue off for a second and tell you, I spoke with a gastroenterologist last week who had a hybrid practice. And half of his practice was in the medical clinic, in the liver clinic, and half of his practice was in a surgical clinic in the liver transplant clinic. Well, in the liver transplant clinic, there was a transplant coordinator nurse who managed almost all of the inbox. And so he seldom needed to do any inbox work for that practice. Whereas in his medical practice, it was more typical of most internists, whether subspecialty or specializing in general internal medicine, where more often than not, the physician was the first responder. If we value physicians' unique skills and talents and limited resources, we would not waste it in the model of half of this doctor's practice. We would model after the other half, where he had much more high-level support. Again, back to your original question, resources. Go upstream on the inbox, tame the inbox. Second, develop advanced models of team-based care with rational distribution of tasks according to skill level, and build up that size, stability, and skill level of the team. And then the third is the Steps Forward toolkit that Drs. Jen Brown and Shannon put together with very practical suggestions on how to improve the opportunities for taking real time off.
Terrific. What haven't I asked you yet that you want to make sure we talk about?
Well, I think where I'd like to end, Kevin, is by connecting all of this conversation to the concept of relationships. I think relationships are the glue that holds us together as individuals at work and outside of work. We need time and space to develop those relationships at work. And we need the stability of those relationships to really work together as a well-oiled machine. We also need time and space at home to develop our relationships, to go on vacation with our spouse, to go camping with our kids, to develop a new friendship group during a hiking vacation. And so I think relationships are so critical, not in a soft and fluffy way, but to the hard outcomes that we seek from our organizations and that we seek in our lives. And there's an opportunity for institutions to provide more support for those relationships, both at work and at home.
That's fantastic. Dr. Christine Sinsky, internist, and Chris, it's still a little hard for me to say this and to believe it's true, former Vice President of Professional Satisfaction here at the AMA, has been our guest today. Thank you so much, Chris, for your time, your expertise, and your willingness to share with our listeners.
Thanks, Kevin. It was great to be with you.
Check out the episode description to explore the resources mentioned in today's episode. And until next time, stay well.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.